All right. Well, thank you everybody for joining us today for our AMSSN ultrasound case series. So like we've been doing, I'm going to start off just a little plug for a few different things. We have our AMSSM Library of Sports Ultrasound Pathology. So this is a collection of sports ultrasound pathologies that any attending or trainee can submit cases to. We're looking for common and rare pathologies. So these cases will be published to the AMSSM website and are a great way to get additional line in your CV and also add to this collection for learning purposes. So if you have questions, there's some emails at the top that you can reach out to. Also a link, QR code to get to that library if you're looking for that. Next, we also have, let's see. So we are also this is kind of our first plug for this, but we have a new AMSSM Ultrasound Case Series catalog. This was spearheaded by our speaker today. And essentially, this is an Excel document that has hyperlinks to the case series. For the specific YouTube videos, it's broken down by body region and pathology for ease of access. So people can easily find what they're looking for and go back to these videos. There are also hyperlinks on this that kind of take you to specific timestamps within the YouTube videos if you're looking for a specific pathology within kind of a subsection there. So it's a really great resource. So here's a QR code that you can access to get to that. But really, I would recommend going to this page if you're looking for anything specific within our YouTube videos so you can find more information and get right to where you want in the videos. It's an awesome resource. So huge congratulations and thanks to the individuals that really put in a lot of strong work for this. So that kind of leads nicely into our speaker for today. So our speaker today is Dr. Ben Kopecky. He is currently a primary care sports medicine fellow at the University of Iowa. He obtained his master's degree in clinical anatomy before attending medical school at Marian University Wood College of Osteopathic Medicine in Indianapolis, and he completed residency in physical medicine and rehabilitation at Mayo Clinic in Rochester, Minnesota. This year, he has served as the AMSSM Sports Ultrasound Committee Fellow Liaison, working a lot on that project that I just mentioned previously. He'll be practicing sports medicine next year in Indianapolis, Indiana. Today, he's going to be giving us our AMSSM Sports Ultrasound Case Series presentation on costal cartilage fracture. So thank you, Dr. Kopecky, and I'll hand it over to you to get started.
Well, thanks everybody. I'm excited to share with you this case on costal cartilage fracture. So I have no financial disclosures. I just want to start with a quick thank you to acknowledge my ultrasound mentors who have just poured into me during my training at Iowa and at Mayo, Dr. Hall, Dr. Cruz, Dr. Sellen, Dr. Betcher, and Dr. Wisniewski. Our learning objectives for today are to describe the ultrasound protocol for evaluation of costal cartilage injury, review the anatomy of anterior ribs and costal cartilage, identify the sonographic findings in costal cartilage fracture, and compose a diagnostic ultrasound report. So starting with our case, we have a 20-year-old male collegiate wrestler who presented 5 days post-injury with acute onset left anteroinferior rib pain after being mat returned during a wrestling match. So if you're like me before I started covering wrestling and you don't know anything about the sport other than the full Nelson, in wrestling, this is the technical term for a body slam. And it happens frequently in folk style wrestling, which is the current format for boys and girls, high school and men's collegiate wrestling in the United States. So his pain was worsened by contact to the area, any type of abdominal muscle activation, and deep inspiration, but not with breathing at rest. Notably, he denied shortness of breath, chest pain, palpitations, and after being unable to return to contact without pain, he presented to our clinic. So on exam, there was focal swelling of the anteroinferior left chest wall without ecchymosis or erythema. On palpation, he was exquisitely tender in the left anteroinferior ribs in the midclavicular line, and he was unable to complete an abdominal crunch due to pain. Heart, lung, abdominal exam were all unremarkable, as were his vitals. So we obtained radiographs first of the left ribs and a PA chest. Looking at these rib x-rays, we don't see a fracture or dislocation of the ribs. Given our clinical question, it was helpful to obtain this oblique view to scrutinize areas where intestinal gas may shadow the rib. The PHS shows no evidence of a pneumothorax, and we can also use the PHS to count the ribs. As cadaveric data suggests that approximately 5% of people have a non-standard rib count, with 4% of the population having an absent 12th rib. So our differential diagnosis at this point includes an occult rib fracture, not seen on an X-ray, as well as costal cartilage fracture or rib separation, given the traumatic nature of the injury. Slipping rib syndrome is when trauma or deformity allows the cartilaginous edges of ribs 8 through 10 to click, pop, or slip under the rib above. Costochondritis and Tietze syndrome are in the differential. Tietze syndrome is a painful, palpable, non-suppurative swelling of the costosternal joint. So there's not a standardized protocol for sonographic evaluation of the inferior chest wall, but here's what we have developed. So we assess ribs 7 through 12, evaluating these structures where we're able: the rib cortex, costochondral junction, the costal cartilage, the intercostal muscles, and the neurovascular bundle, the sternum and sternocostal joints. And when necessary, we look at the lung and do dynamic maneuvers. So in looking at our equipment and positioning, a mid or high frequency linear array transducer will suffice. We use this 18.5 megahertz transducer. You also want to have a marking pen to mark the area of maximal tenderness before beginning the exam. We found this to be a helpful tool to keep things straight during the exam. As for positioning, the scan can be performed in the supine or lateral decubitus position with the shoulder in a flexed and adducted position. So I just want to review the anatomy briefly. So the first 7 ribs are true ribs in that their costal cartilage articulates directly with the sternum. Ribs 8 through 10 are false ribs, where the costal cartilage connects to the cartilage of the rib above, forming the costal margin, which is this complex cartilaginous structure formed by the costal cartilages of ribs 7 through 10 joining together before attaching to the sternum. The bottom 2 ribs are floating ribs because they don't attach to the sternum or any other ribs. Notably, there's great anatomic variability to the costal margin that we should be aware of. Cadaveric studies have shown that almost half the time, the 10th rib is in fact a floating rib. There's also a highly variable number of these interchondral bridges that you can see here. It's been theorized in the traumatology literature that this variable web-like organization of the costal cartilage plays a role in dispersing traumatic forces along the chest wall. Also of note is that the costal cartilage is composed of hyaline cartilage surrounded by a fibrous perichondrium that contributes to its structural stiffness. So I just want to give a few brief scanning tips to keep in mind to help simplify this evaluation. Because although the anatomy is not overly complex, it is redundant and it can be easy to lose the anatomy as there aren't many unique landmarks. So these tips are meant to help simplify the approach. So first, we're going to count the ribs. And once we have rib 12 or the most inferior rib, we're going to march superiorly, evaluating them one by one, going from lateral to medial, looking in both short and long axis, and evaluating for signs of fracture, soft tissue injury, or an intrathoracic injury. Lastly, just keep in mind that unlike almost all other musculoskeletal ultrasound evaluations we do, this anatomy is moving with respiration, so it's okay to ask the patient to hold their breath when taking pictures or videos, and consider holding your own breath as a way to keep track of that. So we're going to go over 2 methods of rib counting from the anterior approach, noting that this can be done posteriorly, but these may be more applicable to the scan today. So in this first method, you start by identifying the 12th rib in the posterior flank. And from here, you count superiorly, again, referencing prior radiographs to tally the number of ribs present. The second rib counting method utilizes the landmark of the second rib that originates from the manubriosternal joint, essentially 100% of the time. So first you place the transducer in the sagittal plane at the midline of the chest at the superior aspect of the manubrium with the jugular notch in view. Then you scan inferiorly until you see the manubriosternal joint, also known as the angle of Louis, and while keeping the transducer in the sagittal plane, you translate laterally to reveal that second rib in short axis. And then from there, you just count inferiorly. So regardless of which method you choose to count the ribs, after you've done this, I'd encourage you to use your marking pen to number or mark a rib or two so that you have a reference should you lose your place during the rest of the scan. So next we'll begin our rib by rib evaluation, starting with rib 12, which is quite posterior. Um, we evaluate the 12th and 11th ribs in long axis, noting that there's just a sliver of cartilage at the tip of the 12th rib and a few centimeters of cartilage at the tip of the 11th rib there. Moving up to the 10th rib, which is most commonly the lowest rib to contribute to the costal margin. In short axis, we scan the rib medially and laterally to get a sense of its attachment to the ninth rib. And you'll see in this case here, the 10th rib does not connect to the ninth costal cartilage. So next we'll evaluate the rest of the 10th rib in long axis, scanning posteriorly until we visualize the costochondral junction. Here we're looking for any sort of step off, suggesting costochondral separation. And next we'll scan posteriorly a bit more, a bit further to evaluate the cortical surface of the rib. How far posteriorly you evaluate the rib can be determined by your suspicion of pathology in this area. In our case, our athlete was having anterior rib pain, so we only examined a few centimeters of this portion of the rib. So I just want to highlight the contrast between rib cortex and costal cartilage as you evaluate them in short axis. So on the left here, you'll see the typical posterior acoustic shadowing that we have with cortical bone, but you will not see this with the costal cartilage view on the right, where you can fully visualize the lung pleura sliding deep to it. So just something to keep in mind. I also want to call your attention to the presence of these variable interchondral bridges, because if you aren't aware that they exist, they can be quite confusing when you're doing the scan. Here we're looking at a short axis view of the costal cartilage, and as we scan medially, we'll get a long axis view of an interchondral bridge that then dissipates. And so you could imagine that if you're doing this scan and you're not aware that these exist, it could be quite confusing. So to evaluate the costal cartilage, just keep in mind that the long axis, you want to keep the rib in long axis and scan from a lateral to medial direction. So I just want to keep in mind the anatomy here. As you move anteromedially, you'll need to rotate your transducer quite aggressively as the costal cartilage makes a sharp turn, making it challenging to keep the anatomy of view, not to mention the subtle movement of the ribs with inhalation and exhalation. That can cause you to slip off the rounded surface of the rib. So at the start of the cine clip, you can see the costochondral junction laterally there, and we scan medially, and we can see the overlapping edges of two costal cartilage fragments. In this still image, we can see this displaced costal cartilage fracture. So with subtle translation across the area of injury, we can further identify the findings of this injury. So we can see a clean fracture line here. There's a superficial anechoic foci consistent with, anechoic region consistent with the hematoma. There's a hypoechoic foci suggestive of a loose perichondral fragment, as well as surrounding edema and increased Doppler flow in the overlying oblique muscle injury, muscle suggestive of injury. Next, we'll look at this injured area in short axis, further demonstrating the disruption of the intercostal musculature with an associated hematoma there. We can also evaluate the structures deep to the ribs here. So to orient you, when you're this far inferior in the rib cage, you may only see lung sliding with deeper inspiration. But you can see the diaphragm muscle and the spleen deep to the injury. So as the patient breathes, you can see here, there's this mobile anechoic area of fluid that's consistent with a small hemothorax. And so another very important evaluation here is is to look for the presence of a pneumothorax. So keep your eye on that mobile hyperechoic line. So that's the lung pleura moving with each breath, and a sliver of lung parenchyma deep to it in the bottom left corner of that middle video. So when you see that lung pleura sliding, that's a good sign. If there were a pneumothorax, you would not see any movement of that hyperechoic line because what you're seeing would be just refraction off the air in the thoracic cavity and not tissue. You could also evaluate the lung with M-mode imaging, which we did not perform. If you're interested in learning more about the sonographic evaluation of the lung, I direct you to this excellent article in NEJM. So we just saw an example of an injury involving these muscles, but it's helpful to understand the normal appearance of the intercostal muscles as well. So the intercostal muscles are best evaluated in the oblique plane, short axis to the ribs. So we can see the three layers here. So you can see here these three planes, the external intercostal muscle, the internal intercostal muscle, and the innermost intercostal muscle. Um, so the neurovascular bundle sits underneath the superior rib and is organized in this vein, artery, nerve organization. So finishing the anatomic scan medially, we evaluate the sternocostal joints and the sternum, both in long and short axis, looking for evidence of sternocostal separation or localized joint swelling. And we can evaluate the xiphoid process as well, which sort of resembles one of our floating ribs that we saw earlier. Lastly, dynamic imaging of the lower ribs can be performed, which is particularly helpful when evaluating for slipping ribs. We didn't perform any dynamic imaging at the time of this evaluation, given the acuity of the injury and the patient's discomfort and the confidence of having already identified the pain generator. If you are going to perform any dynamic imaging, these three maneuvers can be utilized. Just keep in mind that the principles of dynamic imaging, um, you just want to perform them with the slowest and lowest amplitude movement necessary to reproduce the patient's symptoms. There's an excellent AIUM lecture on YouTube that discusses these more in depth if you're interested. So getting to our diagnostic report, certainly the goal should be to answer the clinical question if possible, which in our case was looking for a pain generator in an athlete with anterior chest wall pain who had a negative x-ray. So in writing the report, we took the approach of a list format to keep things organized, and we will touch on the pertinent positives here that are highlighted. So we saw a disruption of the ninth rib costal cartilage with fragmentation and overlap of the fracture fragments, suggesting displacement. There was edema, hematoma, and diffuse hyperemia at the site of injury that included the oblique and intercostal muscles. And there was a small anechoic fluid collection noted superficial to the lung tissue concerning for a small hemothorax associated with the fracture. So our impression, we have a displaced fracture of the ninth costal cartilage with associated muscle injury. There's concern for a small hemothorax at the site of injury, and lung sliding is present without suggestion of pneumothorax. And a CT scan would provide better assessment of the fracture as well as associated intrathoracic trauma. So finishing up with our case outcome, CT imaging was not pursued as we felt we had a good assessment of the injury and the pain generator. The athlete was not reporting any cardiorespiratory symptoms, so he was cleared for exercise and wrestling activity as tolerated. For pain control, meloxicam was used as well as ninth intercostal nerve blocks, and he was able to return to play about 10 days after the injury with nerve blocks as needed for competition. So I just want to discuss the intercostal nerve block a little bit. The method to perform these is to first start at the site of injury in short axis, scan laterally until you're confident you could identify the fascial planes of these muscles here, and direct your needle from an inferior approach to the target between the innermost muscles here and the internal intercostal muscles. So I don't have any follow-up imaging on this athlete, but here's a case published in the Journal of Clinical Ultrasound by Dr. Bianchi's team, showing a similar pathology to our case there on the left. There's this displaced costal cartilage fracture. And then 5 weeks later, with the image on the right, showing calcification across that fracture site and the associated posterior acoustic shadowing generated by the calcification across the healing component of that cartilage. So I also just wanted to include two brief companion cases just to give everyone a sense of the spectrum of severity that you can see with these injuries. So this first case is a 18-year-old high school wrestler who had a sixth rib non-displaced costal cartilage fracture. And as we scan across superiorly, inferiorly at the site of injury. It's hard to tell if the fracture truly extends the full width of the costal cartilage, but nonetheless, there's a perichondral discontinuity and suggestive of a fracture with the associated overlying perichondral hematoma. So this second companion case is on the more severe end of the spectrum. So this was a college wrestler who had a displaced rib 8 and 9 costal cartilage fracture. And this athlete was in so much pain that they required nearly immediate surgical plate fixation. And this was a season-ending injury for them. So I just want to finish with a few take-home points from our discussion today. So first, mark the painful area and number the ribs to keep the anatomy because the cartilage can be highly variable. Second, performing a systematic evaluation going from lateral to medial is helpful as multiple structures can be involved at multiple levels. And lastly, we should maintain a high index of suspicion for thoracoabdominal trauma and consider the need for further advanced imaging as needed. So thanks everybody. Happen to open it up for questions and discussion.
Excellent
Ben, that was
job.
nice. Ben, that was a nice presentation. Especially, the protocol, oftentimes when we have a patient that has a rib pain, whether traumatic or non-traumatic, we just sort of go right to it and we don't have a system. And so to have a system like any other location in the body is nice. And I like that protocol approach. And I think it's important because when you start to get busier with musculoskeletal ultrasound, you'll start to find that you get referrals for rib pain and occasionally traumatic rib pain. And to have a approach to it will be important. My experience has been that the majority of referrals that I've received are for non-traumatic rib pain, whether it's pain from coughing, MVA, where it's sort of this indirect, where there hasn't been a direct trauma to the chest wall. And I have found that it's really the minority of cases that we see an abnormality, whereas in direct trauma to the ribs is a different story as your cases present. And when I do see non-traumatic rib pain, we really liberally use contralateral comparisons. But the one area that I've seen in the chest wall where non-traumatic rib pain has been helpful is pain at the xiphoid process and then also the sternoclavicular joint. With the xiphoid process, ultrasound can see the variability in morphology. I've seen bursopathies here. I've seen pain just from, let's say, an inverted xiphoid process. And then something that we get pretty frequently too is sternoclavicular joint non-traumatic pain. And we see this a lot where people in their 70s or 80s will just wake up one morning and they'll have a swelling and pain over the SC joint. It's a hard area to image, but with radiographs and with ultrasound, you can see right away. And most of these are just capsular hypertrophy from osteoarthrosis, and why it just, one day becomes swollen and painful is a bit of a mystery. But when it comes to traumatic rib injury like you have, ultrasound is, fantastic. It checks all the boxes. You can correlate with clinical findings. It's a superficial structure. It has variable planes that you can adjust with your transducer. You can get comparison views. And so I would say in the majority of time with traumatic rib pain, we're able to utilize ultrasound to help us with the diagnosis as you suggest. So, and I've occasionally have used an intercostal block in these situations, with a rib fracture. I try not to do too much of that, but I have utilized it. Any comments out there from anyone else in their experiences?
Well, how much is too much, Doug? We'll make Ben uncomfortable. We take care of Iowa wrestling, man.
Go ahead, say that again.
So how many blocks are too many?
Yeah, I that's a good question. And I will often, I would say most commonly, I've used the block diagnostically. Someone has non-traumatic rib pain and we're trying to assess, is this something in the lung? And I've used the intercostal block and determined whether we feel it's, with the structures that are innervated. I've probably only done one for a rib fracture in a mountain biker, and then I've sort of sent them on to the pain clinic.
Yeah, it's an interesting question and one that's certainly doesn't have a right answer, right? But these can get dicey. I'll tell you, these are in combat sports. These are super common procedures that are done at the elite level, probably a lot more frequently than many people might think. And certainly they're not without risk, right? Ben showed those pictures. I mean, you're
Yeah.
tickling the lung, and so that's why it's super helpful. When you're doing these to make sure you understand that anatomy. And then we always are in the habit of I mean, taking very good pictures, videos, documenting lung sliding. I think it's super important to be able to document something like a hemothorax, like Ben did here before, so you know that that's not iatrogenic. So just be smart about them. These are not there's not a straightforward answer, right, in terms of what to do. So you have to have good discussion with the athlete. Um, and understand the
Do you have a rule of
expectations.
thumb, Derek? I mean,
What's
do you have a rule of thumb in terms of these blocks?
no, we do more than we're probably comfortable with. Honestly, these are tough because they're common injuries, and there's something that are really painful. That with a block, the athlete becomes really functional, and without it, they can't really do much of anything. Um, so it's tough because they work. Yeah, and so I don't know. I struggle with this back and forth, but I would just say, like, in the elite level of sport with good informed consent, they can be very effective.
Hmm. Yeah.
And the
But
other,
as we know from high stakes cases in the NFL too, they're not without complication, right?
Right. Oh, yeah. Is it anybody out there have any experience with, again, traumatic onset of pain, high yield with ultrasound? The other area is, noise and clicking, and they can reproduce that click. Oftentimes, I've been able to establish a diagnosis. One other little caveat I was going to just add was when I count ribs, and I see an abnormality, I tend to count both ways, just because of the variability of the actually sixth through 10th ribs, that I will confirm also going the other direction. But in terms of just non-traumatic rib pain, anybody have any experience seeing abnormalities? Because I rarely see the abnormalities, and we get a referral a couple times a month for this.
Yeah, I'm with you, Doug. Like traumatic rib stuff's actually kind of fun because we see all these hard findings. They're pretty cool and usually pretty dramatic. Outside of the occasional slipping rib, and like the adolescent swimmer that'll come in. Man, it's real hard. I don't see a whole lot here at all. It kind of becomes a frustrating exam, frankly.
Right, right,
I would say one thing that Ben taught me here that I think is great, and you kind of mentioned on it too, is the rib counting, but the marking. I never really brought a marking pin out before, and that's a great trick, like to mark the painful spot and then just to like mark a couple of ribs because there's not a quick way to orient here. You're kind of usually in the middle of nowhere, right? You like Ben showed you how to find it from the top and from the bottom, but you're usually working right in the middle. And it's a pain to have to keep going back and forth and counting ribs and stuff. So I think that's a really good trick. Just put the marking pin on, and that way you can just quickly orient yourself, and it probably cuts your scan time in half if you actually care to to comment on which rib level you're at.
yeah. I actually caught that too, Derek. I was just thinking how many times I go back and count, thinking, I should be doing this. Yeah. So thanks for bringing that up.
Yep. So that's all Ben, man. I'll give him credit for that.
Thanks, Ben.
Well,
happy
thank
to.
you, Ben, for a fantastic presentation today and a great systematic approach to a rib scan. I think it's really helpful for any fellow who's new to this because it's certainly not an area that we scan very frequently. I'll kind of give just like 30 seconds more if anybody has any other questions or comments. But if not, we will conclude today's session. So I appreciate everybody joining today. And again, thank you, Ben, for a great presentation.
Thanks, Evan. Thanks, everybody.